Our next speaker, should be a rock star. She has a name like a rock star, Shazah. So she's the director of NCMA's Women's OBGYN Center, and Shazah Khawaja, and she'll be talking to us today on endometriosis. So welcome, Shazah.
Thank you. Thank you. Good afternoon, and thank you for still being here. I know it's been a long day, and I'm hoping that I can really let you guys know a lot about endometriosis basics and what we can possibly do for our patients. I am blessed and very fortunate to be the practice director of the Nickimja Women's OBGYN Center, and a leader only shines because of their amazing team. So I have a new partner, Dr. Erin McDonald, who's here today. And my amazing midwifery team of Cecilia Rondeau, Suzanne Saunders, and Kirsten Eckert. One is working today, and the other two would have loved to be here, but they had prior engagements. So, endometriosis. It's a disease that women have to deal with for the longest time without real awareness from the medical community. Being in the position of dealing with this on really a daily basis reminds me of how debilitating this can be for women. Incessant pain, frustration, and tears of desperation are just a few scenarios of patients that present with endometriosis. So let's just start off with like a brief overview of the disease and what we can do about it as practitioners. Okay. So what is endometriosis, right? Endometriosis is characterized by endometrial-like tissue that is outside the uterus and associated with pelvic pain and infertility. Okay, so you have displaced endometrial tissue, which most commonly can be found in the peritoneum, can be found in the ovaries, and in the rectovaginal septum. However, no one realizes that a lot of the times it can be in the thoracic cavity, it can be in the liver, it can be in the kidneys, it can be in the bladder, and then my personal favorite, abdominal incisional implants. I just took one out last week. So a patient who has endometriosis goes through a C-section. What happens? There are abdominal implants. During the C-section, you have a delivery, but endometriosis can totally implant within other layers. So this poor patient, who was complaining about incisional pain for years, came to me, and a lot of the times, we don't know. Maybe it's because of adhesions. She went through lidocaine, trigger point injections, but then we found out that she did have a history of endometriosis. So I had an implant that I took out, which was about 4 to 5 centimeters large, that infiltrated through the subcutaneous layer, through the fascial layer, to the rectus abdominis. She is now very happy. So basic lesion distribution, where is it? In the ovaries, 40 to 50% of the time. Peritoneally, 20 to 30% of the time. Bowel, 10 to 20% of the time. And also the ureter and bladders, which is less than 10%. What do these typical lesions look like? Well, like I said, we have superficial ones, which are in the peritoneum. And then you also have them in the ovaries. Then you also have the age-old endometriomas. So this is what, pulling back to med school, okay, endometriomas, remember those nasty ovarian cysts you used to see with the chocolate-filled fluid? Yeah, those are horrible. And then, of course, we have deep infiltrating endometriosis. So that involves the bowel, it can involve adhesions to the bladder. So as an OBGYN, going into a lot of these cases, if we have something which is called a frozen pelvis, we always like to anticipate if this is going to be a situation where we might need a general surgeon or a urologist to come accompany, because adhesions can form dangerous situations. So who and how does this affect women? Women of reproductive age, 6 to 10% of them are affected by endometriosis. Women with infertility, 20 to 50% are affected by endometriosis. And the big one, chronic pelvic pain. 71 to 87% of women due to endometriosis. It's an estimated 4.1 million women in the US have been diagnosed with endometriosis. What are the risk factors? Endometriosis affects women throughout their reproductive years, with an average age at the time of diagnosis of 27 years. According to ACOG, risk factors, so these are things as our primary care physicians, if patients are saying early menarche occurring before age 11, shorter menstrual cycles, less than 27 days, and then heavy prolonged cycles. This is a question I get from many of my patients. How did I get this, doc? The picture, unfortunately, is never straightforward. And that is why each and every patient has their individual presentation of symptoms. So the most commonly thought etiology or pathogenesis is retrograde menstruation. However, there is a lot more to it. There's an autoimmune factor, there are genetic factors. There is a combined picture that actually affects and brings about endometriosis. It is never straightforward. There's no black and white with this disease. One thing that we do all agree with is that endometriosis is an estrogen-dependent disease. So, pelvic pain, sensitivity to pain. Higher circulating estradiol levels correlate with pelvic pain. Vascularization, elongation, branching, dilation of endometrial vessels, all of this is induced by estrogen. Innervation, excess estrogen promotes abnormal innervation of endometriosis, and that plays a crucial role in pain generation. And the big one, when patients come in, I feel bloated, I feel inflamed. Inflammation, estrogen plays a role in increasing cytokines, chemokines, prostaglandins. So, prostaglandins and endometriosis, the big players. Prostaglandin PGE2 and PGF2 alpha, they're produced in excess. Patients with endometriosis experience higher frequency, amplitude, and basal pressure tone of uterine contractions. Dysmenorrhea can result from abnormal uterine contractions resulting from PGF2 alpha. PG2 can induce pain directly. Common signs and symptoms are, okay, so these are pretty common when your patients are going to come and talk to you about this. Chronic pelvic pain, dysmenorrhea, dyspareunia, bladder bowel complaints, excessive bleeding, and infertility. Patients can also report other vague symptoms, nausea, fatigue, diarrhea, constipation, bloating, headache. All of these clinical presentations vary. And endometriosis can also be asymptomatic, including without pain. Pain is not indicative of the severity. And also, being a surgeon, the level of adhesions or implants that you see when you go in surgically does not correlate equally to how much pain the patient feels. Okay, so what do you do with this? Because it's so difficult to diagnose endometriosis because there is overlapping symptomatology with other diseases. So even gynecologically, it can mimic adenomyosis, pelvic adhesions, PID. Always, if you have patients that come in with pelvic pain, please get an STD panel on them. Ask them, when was the last time you did it? You'd be surprised. Ovarian or tubal masses, right? Hydrosalpinx, ovarian cysts, those also cause pelvic pain. So non-gynecological reasons, we have IBS, you all deal with that. Interstitial cystitis. I seem to think that because of an autoimmune symptomatology and etiology, I think this whole picture may sometimes be related. I have many patients that have all three afflictions. They can have IBS, they can have interstitial cystitis and endometriosis, fibromyalgia, and musculoskeletal disorders. So how do we diagnose it? So laparoscopy, that is our gold standard. It would be great if it could be supported with histological diagnosis too, but it's not mandatory. Association with pain, as I said before. There may be little relationship between the intensity of pain and the severity of the disease. And then clinical evaluation. It's acceptable to make a diagnosis upon clinical evaluation and begin to treat the patient. This is why increased awareness is necessary for endometriosis. Patients have delayed diagnosis. 58.7% of women report seeing 3 or more physicians before they even get diagnosed. 63% of women reported that one physician or more told them that nothing was wrong. And then, this is astounding, 59.6% of women report that they were not taken seriously by their physicians. Awareness, awareness, awareness. Delayed diagnosis is a killer. Okay, so how do we treat this? So far, what are our treatment goals? So our first-line therapy. So our treatment goals are maximize and use medical treatment first. Avoid repeat surgical procedures because you create adhesions. Creating adhesions causes more pain. Reduce pain and other endometriosis-like related symptoms, and improve, first and foremost, the patient's quality of life. So our first-line therapy, NSAIDs, other analgesia, if that's just comfort measures, combined hormonal contraceptives, and progestins. So then our second line, as we know, GnRH receptor agonists, Lupron. So difficult to jump through hoops with insurance companies for patients to even get treated. If they do get treated, the side effects are horrible. Patients end up gaining weight. They go through immediate menopausal symptoms. And other treatments which have worked well, IUDs, so progesterone-only IUDs, and also now the Nexplanon, which is out there with our arm implants. Danazol, we don't really use anymore. Third line, surgery. If you've done all of these, what do we do next? So we try to decrease these adhesions, we try to burn them off, we try to remove them laparoscopically. If, a lot of the times, like I said before, if you have a frozen pelvis, then you may have to resort to a laparotomy. So a general surgeon and a urologist, again, always with you because of these adhesions. Other methods, interruption of nerve pathways. I did actually have a patient who got a walking epidural because of her endometriotic pain. And then, last resort, hysterectomy and oophorectomy. So recapping quickly, approximately 6 to 10% of women of reproductive age are affected. 71 to 87% of women with chronic pelvic pain with endometriosis. 4.1 million women in the US diagnosed with endometriosis. And the big one, average diagnosis by age 27. That is years of pain to deal with. Again, I know I'm kind of harping on this, but what are the symptoms? Because I just want you to be, when you have the patient come in and you recognize dysmenorrhea, non-menstrual pelvic pain, dyspareunia, bladder and bowel complaints, excessive bleeding, and infertility. Remember, endometriosis is in your differential. So there's this new medication that I'm pretty excited about. Elagolix, but everyone knows like the new trade name is Orilissa. Okay, so elagolix, its indication, of course, is moderate and severe symptoms associated with endometriosis. Dosages, just so all of you know, there are 2 doses, 150 milligrams that you do once a day, and then for more severe symptoms, 200 milligrams twice a day. Contraindications, pregnancy, osteoporosis, and hepatic impairment. You can use it with hepatic impairment, but if it's moderate, then you can use the dosage which is the lesser one, which is 150 milligrams. Okay, I'll go through the other warnings and precautions. I have started this medication. It is new, but I have started my patients on it, and I'm seeing positive results. To have a patient come in and say, this is the first time in 15 years that I have been pain-free. I can't even imagine what that existence is. So what's the mechanism of action? So it's an oral, non-peptide, gonadotropin-releasing hormone antagonist. You don't get the flares that we used to get with Lupron. Results in dose-dependent suppression of FSH and LH, and this occurs within 4 to 6 hours of the first single dose. Okay. So randomized double-blind studies were conducted over a 6-month period, and there were extension studies up to 12 months. 75% of 1,689 randomized women completed the full 6-month course of the study treatment. And of those continuing to the extension studies, more than 75% completed a year, a 12-month course of the study treatment. So now we're just going to look at specific symptom improvements at both 3 and 6-month intervals. So you can see that the medication, that there is a 46.4% response for just the lower dose, and then an astounding 75.8%. And that's for dysmenorrhea. Okay. This is a graphic visualization of the Dysmenorrhea scores that I was just showing. Again, but this was over a 12-month period. So this also, the Dysmenorrhea scores decreased in the lower dose and also in the higher dose. The next symptom, non-menstrual pelvic pain at 3 and 6-month periods. 50.4%. Here we go. 50.4% at the lower dose, 54.5% on the higher dose. This is very exciting for me because I've never had patients respond so quickly after being in pain for so many years. And here again, this is a graphic representation of the same non-menstrual pelvic pain over 12 months. And then the other symptom, which is huge, dyspareunia. This affects the lives of patients and their partners. Again, you can see a significant decrease with the lower dose and the higher dose of the symptoms. And this was just a generalized global assessment by patients. You see an overwhelmingly significant view on the higher dose of women seeing improvement here and here. Okay, so what were the adverse reactions in patients who were treated? Okay, so the 2 main were hot flushes. With Lupron, it used to be 100% of the time. There was no escape. But at least with this lower dose, it doesn't have to happen. About a quarter of the time, 24% of the time. And at the higher dose, 46%. I'll take it. Other significant data is that there was recovery of bone mineral density over time. So usually when I have patients, I have them on calcium supplementation during the course of their treatment. Okay, and I didn't mention before, because I would talk about it now, if suicidal ideation, behavior, and exacerbation of mood disturbances or disorders, they should be very carefully screened. Okay. Elevations in LFTs in compromised patients is also a concern. There was one completed suicide on the lower dose, but not on the higher dose. So extremely, extremely important to screen patients. And the common question is, will my period stop during the treatment? Yes, it may, but reassure patients it will resume after the treatment is over. And it's also very, very important to remind your patients to be on some kind of birth control or to be aware that they can get pregnant on this medication. Very important. Voila, a total of 23 pregnancies in the study. So very, very important. So just a summary of the medication. It's a gonadotropin-releasing hormone receptor antagonist. Things to be worried about: hepatic function. And then also, elagolix is associated with expected hypoestrogenic adverse effects, such as, we said, hot flushes, decreases in bone density, and increase in serum lipid levels. And both doses of both the lower and the higher have shown significant improvements in patients with dysmenorrhea, non-menstrual pelvic pain at 3 and 6 months, and dyspareunia was also shown with significant improvement at 3 months. So what's my take-home message to all my primary care physicians? Providers, please listen to your patients. If you suspect endometriosis, it may not be it, but send your patient to a gynecologist sooner than later. Let us all attack this debilitating disease together. Thanks. Have a question here? It's coming. That was a long road.
I had a patient in her mid to late 30s, first pregnancy, C-section delivery, pristine abdomen at the time. Within 2 years, had extensive endometriosis, biopsy proven, and infertility after that. Do you see endometriosis after C-section very often?
Oh, quite often. Quite often. Endometriosis, I have to tell you, it doesn't follow a pattern. It doesn't follow a pattern. It can come about. It's also quite associated with certain dioxins that are in foods. So they're, like I said, the etiology and pathogenesis of this disease is so diverse that at times, yes, you would think that if she didn't have it before, why would she have it later? Things can develop.
So after your 6 months of treatment or your 12 months of treatment, what do you do from then on when the patient gets the symptoms? This is a new medication for me too, and treatment. What we're seeing and hoping, and obviously trials are now continuing, is to see what we can do. Can we do a lower dose? Can we maintain them? How long? And hopefully that this will quell the symptoms. But this is ongoing. But for now, at least we can temporize and help patients with the symptoms. So it is to be seen. Actually, we have been having great luck with it. We've been having great luck. Initially, when it is prescribed, I always tell my patients it will be denied. It will be denied. And then we have to jump through hoops of a pre-authorization, and we're getting great results and getting them covered. So they will get denied initially, just tell them that.
But is this something a primary care doctor can do?
You can do it. But I would think that probably you would want your patient to be connected with a gynecologist, but you can start. There is no reason why not.
And do the transaminases normalize after treatment?
Yes, with moderate, but not with, you wouldn't give it to someone who isn't.
So I understand you're treating the pain, but are you also reversing the disease? Can they expect to get pregnant again?
Oh, yes. They can get pregnant again.
I mean, if they couldn't get pregnant before, if they had that bad infertility, are you reversing the illness? And are you thinking that you may be able to help the infertility with this?
We're hoping.
I see.
Again, this is something, we have to see long-term. We have to see long-term effects of this disease. And the best way, and again, you can't really, even surgically, if you were even to do a surgery of laparoscopically prior to the medication than afterwards, there is not a real correlate. So there are a lot of questions still.
Just
Yes.
to make sure I've got this clear, you have to do a laparoscopy to diagnose endometriosis?
No, you don't. Because I said, in order to definitively diagnose it, yes. But I wouldn't say or deter from clinically treating anyone if they have not had it. But definitive diagnosis, yes, gold standard.
Question here. How do you get GNRN agonist and antagonist to achieve the same result?
I'm sorry, I don't see where you are. Oh, I'm sorry. Say that again?
The mechanism of GnRH agonist and antagonist achieving the same results. Lupron being agonist and
Correct.
this is antagonist.
With the agonist, you get a flare, and so it's different. And I have just anecdotally been with so many patients on the Lupron, but with this, there is no agonist action, it's only antagonist. Mm-hmm. Correct. Because FSH and LH ebb and flow.
Two questions. One kind of related. Since estrogen is kind of an exacerbating hormone, how does the combination oral contraception help? And then second question, from a primary care workup, your preferred imaging, what would you recommend?
Okay. Preferred imaging, I would say right away in the beginning, just your transvaginal ultrasound, just to rule out if there's any other pathology going on. Later, you can always, if there is question upon the ultrasound, you can always get an MRI that can delineate if we have to go surgically, can help us. And then with birth control pills, that's another double-edged sword, because I was speaking to, because we have to put them on birth control because they're on the medication. So at the same time, we still don't know long-term whether it's going to be only the medication, and then the only other way that we could possibly prevent pregnancies is maybe using a non-hormonal IUD, or progesterone only. So that might be the preferred method. But for right now, we don't want to deter patients from being covered.
I'm just more concerned that it seems like combined OCP
Would exacerbate, yes, yeah. Not yet. I mean, I've started literally with maybe 5 to 6 patients of mine. So I've had patients on with birth control and without. Yeah. Any other questions?
Over here.
Oh, there you are.
So is it teratogenic, or you're just trying to be careful? I mean, if infertility is one of the person's main concerns, and they're 27,
It's not.
and they
It hasn't
want to
been shown to be teratogenic. No.
Okay.
Any other questions? Okay.
Any other questions? All right. Thank you very much, Shazah.